In this video, I will outline a petrosectomy and blind sac closure for a patient with extensive cholesteatoma. This patient was a woman in her mid-20s who had suffered with a number of years of recurrent foul-smelling otorrhea and right-sided hearing loss. Audiometry demonstrated a conductive hearing loss with preserved bone conduction thresholds, and CT demonstrated extensive middle ear and mastoid opacification with erosion of the posterior ear canal, the posterior semicircular canal, and the tegmen and sigmoid plates, all in keeping with cholesteatoma. At the start of the procedure, we see an intact tympanic membrane with no retraction, but a subtle posterior-superior bulge suggestive of congenital cholesteatoma. There's also an erosion of the posterior-inferior canal wall. I begin with a post-auricular incision and an anteriorly based palvar flap using the Magithia sweep. The canal re-entry is made as medial as possible, just lateral to the defect in the external auditory canal, to preserve as much lateral canal skin as possible should a blind sac closure be needed. Given the erosion of the canal wall, this ear will require at the very least a canal wall down approach. I therefore begin with a front-to-back mastoidectomy to identify the lateral extent of the disease and to establish the position of the antrum, which helps triangulate the facial nerve. At this point, it's worth revisiting the principles of cholesteatoma surgery. Cholesteatoma forms an irregular three-dimensional mass surrounded by several critical structures. It's often difficult to appreciate the full extent of disease or the degree of involvement of each of these structures. The disease often originates posterior-superiorly, extending through the adductus and into the antrum and mastoid. It may extend all the way posteriorly towards the sigmoid, superiorly towards the tegmen, anteriorly towards the anterior epitympanum and supratuberal recess, and it may involve the medial structures such as the semicircular canals and the facial nerve, along with the ossicles. Laterally, the sac is obscured by the mastoid cortex, and my approach is to identify one boundary of the sac, usually laterally, and then follow it circumferentially. Here we can see the tip of the Thomason dissector lying within the sac. I remove the bone lateral to this to expose the lateral and inferior margins, and this region is relatively safe and far from key structures. As the bone is removed, the edge of the sac becomes visible. I use adrenaline-soaked cotton pledgets to elevate the matrix from the surrounding bone. This defined limit then guides further bony removal. As I work more posteriorly, I remain mindful of the sigmoid sinus, which in this case is dehiscent and therefore requires particular caution. Here, a shelf of bone, Kurz septum, can be seen lateral to the cholesteatoma mass in the antrum. This is reduced and then removed. The sac continues superiorly towards the tegmen, so I remove the lateral bone in that direction. When drilling near vital structures, I switch to a 3mm coarse diamond burr, which is less likely to violate these key structures. We can now see the sac mobilized from its lateral, posterior and inferior aspects, along with it being released inferiorly down from the tegmen. Medially, the sac lies close to the posterior semicircular canal and the facial nerve, both of which are likely dehiscent, and so sharp instruments are avoided here. Instead, a large adrenaline-soaked cotton ball is used to gently dissect. The dehiscent facial nerve and defect in the posterior canal are clearly visible. I then continue bony removal anterosuperiorly to chase the cholesteatoma towards the anterior epitympanum. In congenital cases, this area demands meticulous attention as it is frequently involved. An extended scutectomy is performed to improve access to the facial recess and sinus tympani. Here we can appreciate the transverse segment of the facial nerve, the second genu, the vertical segment, along with the round window niche. We can also note an absence of the SAPI superstructure. At this point, I'm satisfied with the clearance within the anterior epitympanum, retrotympanum and mesotympanum, but I revisit the posterior epitympanum. On closer inspection, there is still some inflammatory tissue adjacent to the tegmen, and palpation expresses some frank pus. As the tissue is dissected, further cholesteatoma is identified and removed. and the surrounding bone is polished with a coarse diamond burr to sterilize any squames. Posteriorly, further disease remains in close contact with the sigmoid sinus and middle cranial fossa dura. Again, pus is expressed on palpation. The surrounding bone is removed with great care, and it becomes clear that the disease tracks posteriorly behind the sigmoid. I attempt to access this from the contralateral side of the table, but this is unsuccessful. An endoscopic inspection confirms residual disease here. I therefore remove the remaining bone off the sinudural angle to gain full access. Once this is removed, the remaining cholesteatoma can be delivered in its entirety with no visible residual disease. Here we can see the dura of the posterior and middle cranial fossa, which are exposed but remain intact. Given the extent of the disease and the large areas of exposed dura, an open cavity would be inappropriate, and so a blind sac closure is required. All remaining external ear canal skin and tympanic membrane are removed medially. A round knife elevator or a Freer's elevator can be used to dissect this. The middle ear is sterilized with a KTP laser, including the epitympanum, to eradicate any microscopic squamous debris. The entire cavity is systematically assessed to ensure there is no residual disease. And here we can see a small area of the dehiscent posterior canal. The lateral canal skin is then elevated and prepared for closure using the fish technique. A 3/0 vicryl is passed through either side of the canal and delivered through this lumen. Three such sutures are placed and then secured using clips. I prefer to first tie 2 sutures, and before tying the third I fill the lateral canal with skin glue as a leak test, reflecting the ear forward to check for ingress of the glue. Once satisfied, the excess glue is aspirated and the final suture tied. Next, abdominal fat is harvested from the left iliac fossa to avoid future confusion regarding abdominal surgical history. Fat can be obtained with minimal bleeding, and if hemostasis is adequate, no drain is required. I also harvest a small amount of temporalis muscle. I prefer this to bone wax, as wax can extrude or provoke inflammation, whereas muscle is generally well tolerated. The muscle is divided into 2 pieces and used to pack the eustachian tube. Because of the exposure of the facial nerve and posterior canal wall and dura, I line the entire cavity with Biodesign before placing the abdominal fat. However, given that frank pus was identified earlier, one could reasonably elect to pack with an antiseptic dressing and return at a later stage. The palpal flap is closed over the packing and the skin closed. By post-operative day 3, the bone conduction thresholds are retested and are preserved, which is reassuring. Unfortunately, 7 days post-operatively, the patient represented with dehiscence of the postavicular wound, with copious malodorous discharge consistent with pseudomonal infection. She returned to theatre where the fat was found to have liquefied with extensive inflammatory debris. This was evacuated and replaced with the length of BIP ribbon, left in situ for 3 weeks with weekly reviews. 2 weeks later, the wound had improved significantly. However, she reported new onset disequilibrium, and repeat audiometry showed a drop in the high-frequency bone conduction thresholds. I therefore removed the BIP earlier than planned and arranged close follow-up. A week later, there was a small area of granulation within the wound, which was cauterized, which fully healed 2 weeks thereafter. The blind sac closure remained intact, and her hearing returned to normal. Her facial nerve, crucially, remained preserved throughout. She reports no further pain or discharge. I will continue to monitor her closely and arrange an early diffusion-weighted MRI at 3 months post-operatively, with a view to repacking the cavity with fat if she remains clinically well. I hope you enjoyed this video. please consider liking and subscribing for further content.